Good evening, everyone, and welcome to the ninth masterclass of the Jaipur surgical tutorial on the topic of abdominal tuberculosis. Jaipur surgical tutorial is an online educational activity which was initiated about 3 years ago by my new institution, the Mahatma Gandhi Medical College and Hospital in Jaipur, in India. And the activities of JST have been managed by my colleague, Dr. Anand Nagar, who's an associate professor of HPV surgery and liver transplant at my new institution. As a regular activity of JST, we conduct a teaching session every Saturday, 9 to 10 a.m. India time. In addition, we have recently started an afternoon activity because the morning activity was not possible to be attended by colleagues in Africa. So on their request, we started Jaipur Surgical School, which is every Friday, 3 to 4 p.m. And this is being looked after by my colleague, Dr. Piyush Varshne and Dr. Kailash Kudia. Dr. Piyush is my former fellow from SGPGI, who is at AIIMS Jodhpur. And Kailash also is my former fellow from SGPGI, who is currently at AIIMS New Delhi. In addition, we conduct these master classes, which are once in a month, last Thursday and Friday of the month, 7 to 9 p.m., where we discuss one topic in two parts. And the previous sessions have been held on safe cholecystectomy, living donor liver transplant, acute pancreatitis, chronic pancreatitis, intensive care, care of a critically ill patient, and several other topics. In between, I will be giving information about how to join Jaipur Surgical Tutorial and the Jaipur Surgical School and how to join the future master classes. I will also inform about our annual academic activity, which is called Jaipur Surgical Festival. We've already had 3 sessions in the last 3 years, and this year will again be on the first weekend of December, which is 6 to 8 December 2024. And the theme this year is complications in surgery. Also, I'm very happy to inform that for these activities now, 2 very senior surgical colleagues, Dr. Sitaram, who was earlier the chief of HPV surgery at CMC Vellore. He has agreed to join our sessions. He's joined today's session also. Welcome, Dr. Sitaram. And Dr. Piyush Sani, who recently retired as the chief of GI surgery from AIIMS New Delhi. And he was also the president of the Indian Association of Surgical Gastroenterology and the currently continues to be the editor of the National Medical Journal of India. He also has agreed to join our online educational activities. For this masterclass topic is abdominal tuberculosis, where I am joined by 2 of my young colleagues who were again my fellows at SGPGI earlier, Dr. Sasmal and Dr. Saurabh Galoda, who have contributed to some of the chapters that we have written on abdominal tuberculosis. Another colleague of mine who has worked with me on abdominal tuberculosis is Dr. Muhammad Ibrarullah. He could not join as a panelist because of the Ramadan month going on, but he said that if he's free, he will join in between. So if he joins, I'll request him also to make some comments either today or tomorrow. So with that brief introduction of our online educational activities, I hand it over to Dr. TD Yadav, who's going to moderate the sessions today and tomorrow. Dr. Yadav is the professor of surgical gastroenterology at Postgraduate Institute of Medical Education and Research in Chandigarh. So over to you, TD, to start today's proceedings.
So good evening, sir, and thanks. We always we are indebted to you to start these academic activities which are being run, and I come to know that people, so many people from all over the world are joining and taking benefit from this academic activity. So as sir has introduced, this is abdominal tuberculosis today and tomorrow. And the first talk is to be given by Dr. Prakash Sasmal, who is a professor of surgery at Bhubaneswar, Alina Institute, Bhubaneswar. So he's going to talk about abdominal tuberculosis, when to think of the abdominal tuberculosis. And Dr. Prakash, please start. Then we will give our comments at the end. Please go ahead.
Good evening, sir. Good evening, esteemed faculty and dear colleagues. With due respect to my mentor, Professor Kapoor, I will be today trying to do justice on this topic because majority of the audience present over here must have definitely got the experience of dealing a patient or many patients of abdominal tuberculosis. It's a nightmare, definitely. So, abdominal tuberculosis clinical presentation I'll be trying to cover up. Then, when to think of tuberculosis, something I'll try to catch. So, greetings to all of you from All India Institute of Medical Science, Bhubaneswar. Let me first go to a clinical scenario as a state induction. And this is a real case scenario. A 42-year-old male was admitted to the emergency with a history of recurrent generalized abdominal pain, fever, night sweats, anorexia, and weight loss over 1 month. He provided no history of close contact with tuberculosis patients, although he had a history of chronic recurrent cough. On clinical evaluation, he was malnourished, distended abdomen, and oil filled with generalized mild tenderness present all around the abdomen. Radiological evidence of intestinal obstruction was there with multiple air fluid level, with a suspicious IC junction mass near the IC junction, as was evidenced, and the air fluid level was till the IC junction. So this is the usual scenario you will be getting majority of the patients in the emergency setup. Besides this, you also will be encountering cases who will be coming with the dire emergency like perforation peritonitis and several others. So we used to think whenever we do not have any diagnosis with us, no diagnosis with us, we are confused. Is it really a mass in the IC junction area, malignant mass, or is it a Crohn's disease, which is although not that common in India, ulcerative colitis, original ileitis, or even if it's typhlitis. So we usually ascribe that, is it a tuberculosis we are messing up? So that is the commonest diagnosis when no common diagnosis could be made. So it is very confusing in the very beginning to state. So these are the few of my operative photographs in case of these surprises which we got in the emergency while operating. So in one of these conditions, you can see the mesentery is just, it was thickened and mesenteric lymph nodes were there. There was a stricture at the IC junction area and it was suspicious to be malignancy, but the patient was young, around 30 years without any history of significant weight loss and no history of even contacts with tuberculosis patient. So it was very confusing. Ultimately, we had to land up with a limited hemicolectomy as it was not a mass lesion, only the lymph nodes and it was a stricture type. So it was highly suspicious of tuberculosis. And the other one you can see, we could not simply open the abdomen. This was a case of a cocoon, but the patient was in intestinal obstruction. To give a chance in the emergency, we operated, but in the end, we only closed the abdomen. The other one you can see, if you are lucky enough, you will be getting a transparent membrane type occasionally in patients where the is present with intestinal obstruction, but you will be finding this type of membrane there with a segment affected, and you will be taking it out or you will be doing adhesivolysis sometimes and sending some of the lymph nodes or the if resected excised specimen for the histopathological report, then you may be lucky to get a evidence of tuberculosis. With this brief introduction, I'll be trying to cover up what is abdominal tuberculosis, brief overview of the disease and clinical presentations, because without knowing the myriad of the symptoms or about the different presentations of the abdominal tuberculosis, it will be futile exercise just to ponder around the clinical presentations. So abdominal tuberculosis, friends, is a chronic granulomatous disease caused by microaerophilic bacteria, which we were taught in the microbiology, medicine, and number of gynae and surgery. So all the textbooks will be definitely making a comment about tuberculosis. But abdominal tuberculosis, basically you will be dealing with when you are a surgeon mostly, and includes a tuberculosis infection of the GI tract, because this mycobacterium tuberculosis can affect from the esophagus right till the anus. So no GI tract is immune for development or resistant for the emergence of this tuberculosis bacilli. So mesenteric lymph nodes, yes, after this GI tract is involved, they may also involve the mesenteric lymph nodes, and thereafter caseous necrosis, and there can be adhesion. In one of the case, we found intestinal obstruction. We went inside, we found a pocket of pus with the segment of the bowel adhered over there, and when we opened up, it was a pocket of pus, and it was sent, some caseous necrosis type was suspected, sent for biopsy, came out to be tuberculosis. Peritoneal tuberculosis, yes, another entity where there can be diffuse, again, this just like metastatic lesions, you will be finding throughout the peritoneal cavity, white caseous necrosis or white just metastatic lesions like will be studied throughout the peritoneal cavity. This will be highly confusing with that of the, again, malignancy. So tuberculosis of the GI tract, if we try to focus, now you will be thinking that most of the cases of this abdominal tuberculosis are secondary to pulmonary tuberculosis. Is it so? Not really. Only 15 to 18% of the patients with abdominal tuberculosis have active pulmonary disease, and only up to 25% of the patients will have some radiological evidence that they are having probably some old healed lesions or calcifications suggestive of a old tuberculosis which just asymptomatically got cured or got again controlled. Now, a fraction of the extrapulmonary tuberculosis that manifest in the GI tract, intestinal tuberculosis, accounts for only 2% of the tuberculosis globally. Routes of the spread, if we see, intestinal tuberculosis, we all know it spreads from the swallowed sputum in case of active pulmonary tuberculosis. Mycobacterium bovis from the unpasteurized milk ingestion also causes the intestinal tuberculosis. From intestinal tuberculosis, the disease or the microorganism can spread to mesenteric nodes and also to the peritoneum, causing again those symptoms because of the peritoneal dissemination or the lymphadenopathies. Hematogenous spread, yes, also noted, and lymphatic spread also noted. So it has been also stated that this intestinal tuberculosis can be also carried on, this bacteria, from the active pulmonary lesions from the pulmonary side by means of this hematogenous or the lymphatic spread even. And directly also spread from the adjacent organs can do occur also. In case of females, you will be knowing that the ovarian organs are also affected, and they can also include the peritoneal cavity. So multiple routes of this infection can occur. Now, pathology and pathogenesis, if we see, Mycobacterium tuberculosis, infected sputum we discussed, ingestion we discussed, hematogenous and lymphatic we discussed. All these are trapped in the Peyer's patches. That is the logic of, again, ileocecal tuberculosis, which we will be knowing, and the residents joining over here ought to know about it. So they can affect or lodge in the ileocecal region, causing ileocecal tuberculosis, or they can cause, again, transverse mucosal ulcerations, or they can cause mesenteric lymphadenopathies. Now, the ileocecal region is commonly involved in tuberculosis due to the following reasons. Why? 80 to 90% of the cases of this abdominal tuberculosis are concentrated in that region. We all know these are the common questions asked. So, rich lymphatics in the Peyer's patches, yes. The presence of a neutral media favors the growth of the organisms, and the presence of ileocecal valve precipitates stasis for the mycobacterium to grow and also gets absorbed in that region. So, these are the few of the conditions why there is a frequent predominance of the ileocecal tuberculosis. Comparison of the two forms of the intestinal tuberculosis, it is very common, we all know, and that is ulcerative variety and the hyperplastic variety. But we should know that the ulcerated variety will be found in almost 60% of the cases. So those patients will be having a very poor resistance, that is, the immunity is poor in those patients. Whereas the hyperplastic variety, which often we tell that the differential diagnosis of a malignancy in the ileocecal region is the tuberculosis, is present in only 10% of the patients. So that is most commonly due to the ingestion of the Mycobacterium bovis from unpasteurized milk intake, and that will be also affected in the ileocecal region, will be confusing with, again, malignancy, but the immunity, if we see, is good in the patient. That is why that's a hyperplastic variety. And the rest 30%, if we see, is a ulceroproliferative type or a hyperplastic type or a fibrotic type, which often or very often confuses with that of malignancy even. Modes of presentation, if we see, as I told you in the very beginning, when you could not think of any diagnosis clinically, then you think of tuberculosis, are we missing it? Yes. The modes of presentations can be acute, or it can be chronic or subacute, or acute on chronic. In the emergency, mostly we get acute on chronic, but most commonly we get a chronic or a subacute condition. That means patient will be having all the vague symptoms as will be described later on. Now, challenges in the diagnosis. Median time from symptom onset to diagnosis takes around 4 months because the patient will be confused and will be confusing the physician, attending physician or the surgeon. Really, what is the diagnosis? So it's an indolent disease. Symptoms develop slowly over time. The symptoms of the abdominal tuberculosis are often non-specific, such as fatigue, weight loss, and abdominal tuberculosis most often presents with complications like intestinal obstruction or fistula formation, which can overshadow the underlying tuberculosis infection and delay the diagnosis. So with this, the clinical symptoms mostly found and in the literature which I found is that abdominal pain is the most common symptom with dull, vague, or the colicky type of pain, if at all there is a subacute or acute intestinal obstruction. Others are there is an alteration of constipation with diarrhea. Usually in case of malignancy, on the left side we find constipation, on the right side we find mostly anemic features. But if there is an alteration of this bowel habit, maybe diarrhea and sometimes constipation, then think of a tuberculosis. Non-specific symptoms like fever, sometimes feverish or evening rise of temperature, there can be excessive flatulence, or there can be noisy sounds in the abdomen because of the subacute obstruction or adhesions. And the patient will be telling that always my abdomen is making a noise or sound. And there can be abdominal distension for which the patient may be also seeking the help of a physician or a surgeon's attention due to ascites or subacute intestinal obstruction. Weight loss is very common, of course, because of the disease itself and also because of the poor appetite and because of the, again, weight loss, and also the patient is also having this intermittent obstruction. So there will be malnourishment as in case of pulmonary tuberculosis. So the general symptoms, if we see, fever, night sweats, weight loss, anorexia, malaise, and fatigue. But nothing will be just clicking in your mind. Is it all because of tuberculosis? Because you will be thinking fever, okay, let me rule out some medical causes, and night sweats, is it a lymphoma? Are we dealing with weight loss, anorexia, and loss of appetite? Maybe are we dealing with malignancy? So based on the clinical acumen, experience, and the patient's age, and if at all you are lucky, then any exposure to tuberculosis patient may give you a hint towards a abdominal tuberculosis or Cox abdomen. Abdominal symptoms, if we see, most common symptoms are abdominal pain, and other symptoms are abdominal mass or lump, altered bowel habits, GI bleeding up to 20% of the patients, but they will be only mild, bloating or borborygmy as I was depicting, and acute abdomen, yes, we will be finding those group of patients in the emergency. That means with perforation, yes, intestinal obstruction or pyoperitoneum at times. And those group of patients do have a morbidity and also increased mortality, because really you cannot do a lot if there is a cocoon also associated with. So clinical signs, if we see, patients are either malnourished, pale, abdomen will be just mild, mild generalized tenderness, often distended with visible intestinal peristalsis, distended bowel loops, doughy abdomen in case of peritoneal involvement or a cocoon formation, rolled off momentum may be palpated as a mass or a mass in the right iliac fossa or the lumbar region, or loculated ascites, etc., all clinically detected. So 1/3 of the tuberculosis patients present as acute abdomen. We should not forget that due to intestinal obstruction and perforation peritonitis. So a pertinent history, clinical history is important. Perforations occur in the dilated bowel loop proximal to the stricture. For the postgraduate, one need to remember it. So common confusion will be with other granulomatous disorders like Crohn's disease, sarcoidosis, or fungal infections, but most commonly in our scenario will be a malignancy. So criteria for the diagnosis of abdominal tuberculosis, I'm not going into a microbiological aspect. When you are confused, then the questions criteria one should remember. If any of the 4 criteria are positive, diagnosis is established. That means a histopathology or a operative finding suggestive of tuberculosis or lymph node, or a tissue positive for FB staining, or a tissue culture reveals mycobacteria. Among these, any of them will be positive, means it's a case of Cox abdomen you are dealing. Logan further modified the questions criteria by adding to it the response to ATT as a criterion event. So it is often also practiced nowadays. If you are not getting any hint, then probably ATT or empirically started. If responding, then probably it's a case of tuberculosis. So it's one of the case where we did a limited excision of the intestine. Later on came out to be a gallbladder disease and tuberculosis, and the patient was given ATT. So friends, to conclude, abdominal tuberculosis requires a high index of suspicion as I depicted, and consider tuberculosis in patients with unexplained symptoms. Early diagnosis is crucial, definitely, for the better management of the patient. So thank you all for your patient hearing.
Thank you, Dr. Prakash. Very nicely you have covered the area, but there are certain areas you have probably taken luminal only. So, can you give some comment about solid organ tuberculosis presentation and any way to diagnose solid organ tuberculosis in the abdomen?
Yes, sir. Definitely, sir. Solid organ, I did not touch up here intentionally because solid organ, especially in the liver, pancreas, kidney, yes, you'll be getting. And to the urologist, definitely this tuberculosis of the kidney is an entity which is frequently referred to the urologist, and they do manage it. And in the liver, they will be just ascribing as if it's a case of a metastatic lesion or sometimes abscess in the liver, and along with the systemic signs may be present. So they will be confusing mostly with a metastatic lesion. And there can be also abscess formation in the central necrosis occurs and abscess formation. And they can also lead to just like any pyogenic liver disease, they will be manifesting. Pancreas also in the case, several case reports and series also, pancreatic tuberculosis has been also reported, sir. Yes, nicely stated, sir. About.
Actually, TD, recently, Dr. Piyush Varshney, he has done with me a review on HPV tuberculosis. So I have requested him to make a small 5-minute presentation tomorrow before we start the open house session. So he will be covering this topic in little more detail tomorrow.
Okay,
please.
HPV. So one more important point, we see that there is a fold tuberculosis in the abdomen, or there is a luminal. And it is also, it has been found that combination type of tuberculosis is rare, less than 10%. So once you are finding because sometimes when there is a luminal, there is a stricture, it is very difficult, as you suggested that there are so many differential, and if endoscope is not able to reach that area, and people will start ATT, thinking that in this country tuberculosis strictures are commoner. However, there are lymphoma, there are other strictures which sometimes are surprise once there is a surgical resection. So to have a little bit more area, more discussion about that. So it has been found that lymph node tuberculosis and stricture, if you are finding so-called tabes mesenteric, lots of lymph node lymph nodal disease, and at the same time you are finding stricture or ulcerative part also. So this combination would be a little bit rarer. So we must think about other differential diagnosis. Rest of the points, I think have been covered. Sir, you want to say something?
Yeah. So at the cost of repetition, I would like to reiterate some points which Dr. Sasmal has made. One is that at least in our patients and in countries where tuberculosis still continues to be common, in every patient who has either an acute or a long-standing abdominal problem, tuberculosis has to be kept in mind as one of the differential diagnoses. That is very, very important. Second is, when the diagnosis is not fitting in with a malignancy, then again you should think whether it is tuberculosis. Because you see, if it is malignancy and if it is widespread, obviously not much can be done for the patient except to establish the tissue diagnosis and give some definitive palliative or chemotherapy. But if it turns out to be tuberculosis, it is treatable. It is completely curable. So the point which Dr. TD was making, that if it is a lesion which is surgically or endoscopically accessible, as we will see a little later, every attempt must be made to establish a tissue diagnosis, either for malignancy or for tuberculosis. If the biopsy is negative, you should again try to get a biopsy done. If it is resectable, you should try to resect, because if it turns out to be tuberculosis, it can be treated. So based on radiological suspicion alone of malignancy, the patient should not be condemned to no treatment. We should always try to get the diagnosis as far as possible. And the other point which Dr. Sasmal mentioned, the involvement of other organs in the abdomen, which by definition are not included in abdominal tuberculosis, which is the genitourinary tract tuberculosis, especially the genital tract in females. And in every female patient who has a menstrual irregularity, who has infertility, in whom some kind of a TO mass is present, again, one should think whether the GI symptoms are also related to tuberculosis. That has to be kept in mind. And although it doesn't fall in our domain, but if the patient has symptoms related to the urinary tract or to the genital tract, then along with abdominal symptoms, then again in a multi-system involvement, tuberculosis should be kept in mind. So I think that is the essence of what Dr. Sasmal has presented. And of course, many of these aspects we will be covering in further presentations. Dr. Sitaram, Dr. Kotecha from Tanzania has joined. Would you like to make any comment? Dr. Banerjee is also there. Dr. J.K. Banerjee.
Only
Yes.
one comment from my side.
Yes, sir.
Just like you said, you should not say that the patient has got incurable malignancy without proof. I feel that starting anti-tuberculosis treatment without either histology or bacteriology is not good practice. I feel that every effort should be made to get these two confirmations, and to start anti-TB treatment without proof should be restricted to very, very, very few patients, because anti-TB treatment is not without its problems. And we have seen fairly serious problems in patients who have been started on such treatment without proof. Thank you.
Yeah, I think that's very important. It is known as therapeutic trial, but as he said, it should be done in the rarest of rare cases. Every attempt should be made to establish the tissue diagnosis, because the reverse is also true. What we are thinking of as tuberculosis may actually be malignancy, and then the treatment of malignancy would be delayed. And of course, Crohn's disease is the great mimic. Somewhere in the discussion, that point will come. So, TD, I think we can proceed, please.
Yeah, yes, sir. Thank you, Dr. Prakash, and thank you, sir, and Dr. Sitaram, sir, for good comments.